Schaefer. I'm Director of the Learning Community. Primary care teams from Effective Ambulatory Practices, PCT LEAP, is a national program of the Robert Wood Johnson Foundation located at the McCall Center for Healthcare Innovation. Today we have a really special call. We're going to be hearing from lay staff members from 3 LEAP sites about their expanded roles. But before we do, I'd like to encourage you all to actively use the chat boxes located on your screen. Ask questions or make comments that the moderators can then pose at the end of the presentation. In the chat box, you might need to move your cursor to the extreme top of your computer screen and click on the chat icon that will appear there. Box, note the send to line. In word arrow to display menu, please scroll down and select all attendees so that everyone can see your comments and questions. It will be recorded and posted on the PCT Commons website very soon after today's webinar. We're going to do our best to make sure that any questions that you pose will be located there in case we don't have time to address them. On today's agenda that we're going to hear from 3 presenters today, with an opportunity to ask questions and comments between presentations, and at the end again. So please chat your questions and comments into the chat box. So we're opening by Dr. Wagner, who will talk a little bit about this very special seminar and webinar and why we chose this topic. And then we're going to be hearing from 3 panelists. First, we'll hear from John Jason, the patient advocate from Neighborhood Family Practice in Cleveland. And we'll hear from Mia Cosney, who is the patient access person at Union Square Family Health Center in Somerville, Massachusetts. And then we'll hear from Lainey Strahan, who is the patient partner at Minster Medical Clinic in Westminster, Colorado. So, Ed, at this point, I'll turn it over to you for some introductory comments.
Thanks, Judith. Good morning. There are exciting observations in our visits to the 30 LEAP sites. But one of the most exciting for me and my colleagues was seeing the wide variety of ways in which bright, energetic lay people, and I'll come back to what we mean by lay people, were doing in these clinics, playing a wide variety of roles, some with direct contact and involvement with patients and patient care, in more practice level or administrative functions like quality improvement or working with information technology to make it more useful to the people taking care of patients. What I mean by lay people is and I hope the term doesn't sound pejorative to anybody, is really descriptive of individuals that don't have a specific clinical background, are finding important ways in which they can contribute to the vision of high-quality primary care. So in this webinar, and colleagues have assembled a kind of representative subset of this large and intriguing group of individual new kinds of roles primary care that I think hold promise for the future. So, in introduction, let me turn it back to Judith and we can get started.
Terrific. Forward the slide to John's slide, please. I'd like to introduce again John Jason, who's the patient advocate at Neighborhood Family Practice in Cleveland, Ohio. So just take it away and just tell Donna when you'd like your slides advanced.
Thank you. Background about my position here at Neighborhood Family Practice. The patient advocate positions got about 5 or 6 years ago, and they were usually based and grant funded and project based around specific patient populations. First patient advocate was worked directly with our midwifery department, kind of doing a combination of case management with newly adopted mothers. Our second patient advocate was again worked with our refugee population. We had him come on working with our Hispanic population, and advocates kind of worked individually, and they're very much kind of detached from the clinical department. Half of 2012, we Neighborhood Family Practice, explored the whole integration into care teams. Now we're working, directly beside the departments, the nurses, and the providers. And the whole, I guess, point behind this was so that we can have paperwork so that everybody can kind of work at the top of their license, and just give them some more experience when they come to the health center. Current care team model, our teams kind of vary. They always include at least one of these members: a physician, a nurse practitioner, a nurse, at least a patient advocate, and a medical assistant. So again, some of our teams have 2 nurse practitioners, a couple patient advocates. It's just, they vary on size depending on the patient panel they have. Go ahead. So these are some of the current skills and responsibilities we look for when hiring new patient advocates. This is encompassing. These are just a few I've kind of are outstanding as far as their importance. Go. Training that we went through that was probably the most helpful was our EMR, our electronic medical record, excuse me. That was probably the most important. It's a tool that we probably couldn't do without. We have standard policies and procedures that help us, I guess, in each situation. Probably the patient advocates, and just learning through, to see what each day is, and then learning the various protocols for proactive office encounters, such as pre-visit preparation for physicals and some of our chronic disease management patients. We try to prepare ahead of time for those. Patient interaction that we have. This is all through our EMR and sometimes through our workflows. It's just sort of a prompt that we use in our system that helps follow along when we're talking to patients on the phone or in the exam room with them. Make sure we cover everything and information is clear.
I wonder if you could take us through one interaction with a patient. Go ahead and say, when would you begin and how would it flow?
when we interact with patients directly, we have encounters we do called face-to-faces, and therefore a specific set of high-risk patients. The way the flow of things is when our medical assistant rooms the patient, we tend to slip in for about 5 or 10 minutes before the provider sees the patient, and we work directly, in our office notes and are able to chart there while talking to them for a few minutes. And just looking at this last slide, going through the one on the left is exactly for a face-to-face for a diabetic patient. So just go through the questions, chart it, and that's about it.
So, rules for us on the team it might be difficult, or it might be a very new experience for them to have lay folks on the team. Can you talk about acceptance on your team, and what has it been like for you and other team members to have you as part of the team?
Oh, okay. I think for me personally, it's been incredibly easy. The people I work with are absolutely fantastic. I think they welcomed me with open arms, in a sense that I was just, I was there to help when they needed something little or thing that hasn't been, necessarily done in a while, and I'm, more than willing to take that on. I mean, the position, was now, and just looking back, it's great strides, we've made since year.
What is the most of the role?
I think another body in your team to help you with something.
I'd like to chime in. I think that the thing that's so helpful about having a patient advocate is having someone to keep an eye on the patients to make sure they don't sort of drop out of our view. So we're really keeping tabs on them and making sure that they're getting the care they need, reaching out to the patients who have the higher needs and making sure that there are things that we need to do to help them with their care that's getting done. And then also the whole pre-order with the workflow for the providers. Again, as John said, making sure that people are working to the top of their license.
What was your background before you became a patient advocate?
I graduated from Ohio State in 2010 with international business. That's probably the closest I've come to healthcare before. Sure.
To extend a lot of trust on patient care issues to folks who haven't had any clinical training. What you've done to trust and really build in this lay role among your team members?
Well, I think that our trainings, when we're changing from the more individualistic model to the team-based model, I think we're very helpful. And I think the providers here are very collaborative. They're collaborating with their patients. They're collaborating with nurses already. And the idea of having more people to help really like a wonderful idea. People do feel pretty overwhelmed, and so the idea that they have people they can turn to, I think, was very helpful.
John, Ed, is there any the roles of the advocate and the medical assistant?
Aside from the few patients who need to visit at the, during the face-to-face that the PA does, other than that, the PA role is really in the back office, on the phone, on the computer, and that role is a very hands-on role. So I haven't had any situations where patients have confused one with the other.
We have some questions from the group. Sarah Hamilton would like to know, could you speak some more about what you do for your follow-up calls?
Okay. A lot of it's case-by-case basis, but what we will do, especially for our chronic disease management population, such as our diabetics and our patient hypertension, we'll follow up with them, to make sure that they're scheduled every 3 months or so to come back in, and and a lot of our providers will just send us messages to make sure the up with patients if they got a certain test done or if they want to see a specialist, if we referred them. So we try to, especially urgent referrals, we try to follow up on those, and really manage the chronic disease patients.
So an attendant question is from Hadassy, is there any elements of behavior change involved in your role? And if not, who on the team has these kinds of conversations with the patients?
You said what could change?
Change. How patients change their behavior and do self-management support.
When we're trying to do that kind of change, we use our wellness coordinator, who really sits down with the patients to talk about lifestyle changes. I think advocates are more look for barriers to care and trying to reduce those barriers.
Thanks. The analyst is asking, do you all have community health workers also?
Do we have health workers?
Do we have?
We goes outside the building. We do as far as outreach. We do quite a bit of that.
We send various people to different kinds of health fairs. We work with there's the Substance Abuse Rehabilitation Center. One goes there and with women on their health issues. What else do we do? Individualized to specific needs in the community that we might send a nurse or type of provider out there.
Mm-hmm. Responded to your role, John?
Generally very receptive to, me scheduling their appointments or following up with them. A lot of times, patients want to know what their results were. So, they're great. I've called. I haven't really had a patient that. Sometimes I do have to define my role to the patient and what I do, but I think it's good overall.
They're not necessarily used to having someone other than the front desk reception or perhaps a nurse follow-up or their provider talk with them. Do you find yourself often having to explain your roles? And if so, how do you do it?
Part.
Yeah, you have to explain your role. What way in terms of your role?
On the phone with the patient, I am. A lot of times I get called a nurse, honestly, and I tell them I'm not a nurse, but I work with either that particular nurse or that particular provider, and I once identify myself as a patient advocate, and that, why I'm calling, I think they kind of understand that this, this call isn't necessarily clinical. It's just kind of, more of a follow-up or something like that.
Question from Nancy Fishman. How much follow-up to this community resources does the advocate do?
As far as direct patient connection, or even through the phone, patients will discuss, or sometimes even the provider will send us a message if it's a question the patient posed in the room, and we do keep a pretty up-to-date list of all of our community resources here on the Near West Side, and even in other parts of Cleveland to help assist the patients with whatever they need, whether it be or after school programs or transportation, stuff like that.
Thanks very much, John. You'll stay on, and we'll have a little time for more questions at the end of the webinar. Advance the slide, please, to Nydia Cosme's slide. And now we're going to hear from Nydia Cosme, who is the patient access person at Union Square Family Health Center in Somerville.
Hi, I am a patient access representative. My role includes into scheduling appointments. You can go to the next slide. Sorry. In scheduling appointments, checking in and out patients, and supporting my day basis needs. About maybe like 2 years ago, we created a team model at each primary care clinic at Cambridge Health Alliance. Before, my role was basically phones and make appointments, check insurance, and phone numbers. Now we make sure we get like all family members phone call to come see the providers. We are like in supporting teams, a lot of responsibility when it comes to family support, family phone call. We health maintenance to see what the patients are overdue with, and get them in. To resolve those issues with that one phone call, we either make to them or they make to us. We also talk to the patients who we know had like a hard time, whether they were like discharged or in the hospital or had emergencies. And we're all to just check on them. Also, patients used to just walk out without making follow-up appointments and having lab drawn, getting their referral appointments set up. Now I have a flow where they have to come to check out, and we direct them, make sure they leave with all their appointments set up. If they need a referral, we make sure we send them to a referral coordinator. Also, if they need to have labs drawn, we make sure they get that done before they leave us. Next slide. So we train. The team, basically who does what within our members. So we have I have 3 teams, 3 providers I work with. We have weekly team meetings. They each take a half an hour, once a week. Discuss different patients, what their needs are, who needs to be reached. It has a team meeting. We have 1 provider, a nurse, a PA, and health. We within decide who needs to reach which patient and for which appointment they need. So we do that within. our manager who actually checks in with us. We basis if needed. Otherwise, she does the weekly check. Make sure we're okay. If there's anything we need, we let her know. The performance improvement team, which is a PIT team, they create workflows like for forms that we receive, faxes, like junk mail. What should we do with it? Like different flows, even patient refills requests. PIT team, there's actually a representative, a rep from each discipline, which is one MA, one PA, one front desk, one receptionist, and the manager. So they meet once a week as well. They've discussed what works and work in our clinic, and then they come up with the new workflows and different ways of actually reaching that situation. Last slide. And then provide training, like motivational interviewing and customer service training, and also the care team training, which is basically like how to run teams, which, I just recently attended as well. So when we, first get hired, and if there's anything to improve, there's always a meeting set up for that and training. Next, please. The role work within the team. So we usually try to maintain each patient with their team. Like I said before, I had mentioned we have one doctor, one PA, and we have the team nurse. And there is MA and myself. So when we try to keep them within the teams. So there are more than 3 teams in this clinic. I believe there's maintain them every time they come in. They prefer their own PCP, but their PCP are not available. So we maintain them with their team. So we always provide the other doctors who work within the same team or their PA. We make we try to get every need that every patient resolve at one visit. So if we see that they need a and they're calling in just because they're sick or they need refills, we'll try to, let them, hey, you actually are due for a physical one in, this certain day. We could resolve everything at once. That's how usually we try to get them in that one phone call. As I explained before, we meet, 30 minutes once every week. We talk about the patients who need one appointment, whether it's medication, if they had an emergency, if they were recently to the emergency room, things like that. And from there, we'll decide who's responsible to reach out to them. If it's, a follow-up appointment, then a well visit, or, women's health or screening, colon screening, then, decide who does what there. And that's what we do in the plan care, the outreaches. All right. For example, one of my stories, we had a patient who came in. We also have interpreter services. So we had a patient who needed interpreter services. Most of us already know that at the front desk, what we ask for. So they either come with a slip or IDs, health insurance cards, information to ask for. So and that went in, and I signed her in. I checked her in, gave her all the forms that needed to be signed. Folder that I have to provide will state the interpreter or not. I told she needed an interpreter, so the provider actually interpreted over the phone while the patient was in the room. So everything was explained with the patient as to any forms that needed to be signed or any appointments, anything in regards to the visit. By the time the patient came out, that actually told me all she needs to do is sign a medical release form. I gave her a release form, the PA pulled the line, And then she told me, okay, this is the date, the appointment, because I went to her in the room. That's how we work together in a team. So all that shows how well we work with our teams. We all help each other out. By the end of the day, you know, everybody's settled and happy with how the day went.
Well, thank you, Nydia. There are several questions for you here in the chat box. Could you tell people who's on the PIT team, please?
So we have one of the providers. We have a medical assistant, a physician assistant, a receptionist, a nurse, and a teacher.
Meets weekly to do quality improvement work, or are those provide specific teams?
Quality work.
Mm-hmm. Okay. Paula Eaton asks, do you track the number of phone calls per day? And has this model helped decrease the number of phone calls you get per day?
We do track. And yeah, just because we try to get to them before they start calling us, and we men of times we have to.
How do you identify your patients who need extra attention?
By like all the extra services, they're the ones who contact them, depending on what the situation is. But usually go over.
Mm.
Judith?
Go ahead. Yes?
Yeah, I'd ask a follow-up to that. Nydia, you look at the patient's records to see what health maintenance they need. What prompts you to look at that record? They're in the clinic, or is it something else?
Look at the records when they call in for an appointment, just to see what's missing. Like if they need a follow-up, or especially with planned care, where we bring up the topics and different appointments they might need already. So if we come across a patient that I remember from the planned care, like, oh, that name sounds familiar, I know this person needs this, this, and that, I'll look into just to clarify it, and then from there, we'll let them know. But then we normally do, just because a lot of patients, it's either language barrier, and we always need an interpreter. So to get everything out the way, we normally just look at everything, make sure if they do, try to get them in while they're on the phone.
Could you explain the snapshot? Excuse me, Ed. Could you explain the snapshot view that we saw when we were at Cambridge?
I actually don't use a snapshot. I do. It's medical assistants and everybody basically behind them, like nurses, the doctors, the PAs.
Sorry, do you want to follow up?
I mean, a follow-up to Sarah Hamilton's question, you also, something prompts you to call certain patients. Not that they've called you, but you call them. And where does that prompt come from? Does it come from your team meeting?
Yes, I can. Planned care team meetings.
Great. Thanks.
Patients that you mentioned who that you call when they're having difficulty. What happens? How would you end up calling a patient when they're having difficulty?
Well, it's more like planned care will talk about it to the patients, and either we'll say, hey, can you please call this patient. They were at the emergency room. They got discharged recently. I'm going to come in for an appointment, and if they know what could happen, we'll discuss within the team because the nurses and the doctor would, talk right there, find out what's the next step, what are they planning to do when the patient does come in, how to treat, or who's going to see the patient when they get in. Where I come in and call the patient, I'll reach them, see how they're doing, and then, set the appointment with them and have them come in with whichever provider needs to see them.
At Union Square. I just want to make a comment and follow up to that. So, a report every day will show which patients were either discharged from inpatient or emergency room. And depending on why they were in the emergency room, obviously we have nursing or somebody with a medical background call these patients for follow-up. If it's something a little less minor, a patient had a sprained ankle or something, you need someone with a clinical background to check on, those are the outreaches that we're having our front desk staff make. It's just here we build so many different relationships with patients. We see that the supermarket, they see us, they ask us to schedule their appointments in the middle of the supermarket, things like that. So we get to know our patients, we build these great relationships with them, and, usually we know something's happened in their family or not even anything, probably not even anything medical. So those are the people that we at the desk level try to reach out to. And it's trusted by the team, the doctor, the nurse is asking us to do that.
Oh, thank you. Yeah. Right. Thanks very much, and your helper there.
You're welcome.
Can we go then to the next slide, please, Donna? Now we have with us Lainey Trahan, who is a patient partner. I'm interested in the different names that we come up with to describe these roles from Westminster Medical Clinic. So, Lainey, want to take it away?
Thank you so much. I first of all want to apologize that there may be some echoing. Is that occurring right now, or is it okay?
Right now.
Oh, okay. Well, I was going to say, if the echoing is too bad, just let me know and we can try something different. But yeah, my name is Lainey. I'm a patient at Westminster Medical, and I'll explain second what all that means. Can you go to the next slide, please? So here at Westminster Medical Clinic is health literacy application. And I think it's important to note that we here do not have the expectation of patient health literacy level. However, we do, or my goal is to identify patients who are at high risk for low health literacy and kind of arm the providers with tools and information that they can use to better communicate with the patient in their visit. So one of the things that I've done is, with our medical director, is create something called the patient profile. And this is a form of patient paperwork in which we are using to gather that information to really help the providers when a patient does present as low health literacy. So we gather information on the patient's pulse level, using something called the newest vital sign, and that is a validated tool that is in the form of a nutrition label that's by 6 questions, and the patient's answers to those questions, they're indicated at certain levels of health literacy. And I earmark those that are at risk of low health literacy. Gather information on the patient's personality, which influences their communication style. So I categorize patients into one of 4 personality types. kind of help give information to providers to then communicate with those different personality types in a way that is hopefully as possible. Their information learning style, learning styles, basically audio, visual, or aesthetic. Patients can obviously have more than one learning style. So patients' health culture, and I've kind of defined as where a patient sees value in improving their health. So I got information on, does a patient see that or think that improving their diet would improve their work? What do they think that improving exercise habit improve their health? Stuff like that. So let the providers know. As a patient's attitude towards healthcare. So whether or not that given patient has had a negative or positive experience with healthcare, because if there is a negative experience in the past, then period relationships probably going to occur, as well as within the opposite. I take all the information, enter it into our EMR, which we're kind of ironing out all the details with currently. So I enter the information that the provider can take a look and see, for those with lower health literacy, what information, what extra information we have. Really communicate with the patient on a more efficient level. I also have done many trainings with our staff in our staff meetings on these different components of the patient profile. I've only gone through 2 so far, but we're working on getting through all of them. Next slide, please. I am a former teacher, and while teaching, I decided I wanted to get my master's in public health. And so I did so at the University of Colorado, where I focused on community and behavioral health. As part of my MCH program, we had to do an internship, a practicum, as well as a capstone. I did my practicum and capstone both here at Westminster Medical Clinic, where Dr. Hammond, our medical director, was my preceptor. During those activities, I did a lot of personal development, where I basically read as much as I don't have literacy, anything I can get my hands on, to familiarize myself with the current health literacy research out there, what's being done, where are the gaps, and worked a lot with Dr. Hammond, our medical director, to create that patient profile. So that method of gathering information that helps us achieve a broader group of patients, so that if there is an indicator of low literacy, we have other things to go back on as well. How does my role work within the team? In the future, we are working towards creating something we call a shared care plan that helps with communication within the various care teams. So as part of that shared care plan, there's a social determinants component, which is the thing that I work on. And we plan on doing this with our complex patients, so patients that present with multiple morbidities. And it will be started in the form of an extended office visit. That's with me, the patient partner. I do that patient profile of the patient, gather this information on social determinants, patient health literacy level, and all the other things that I mentioned before, as well as patient goal setting, and then discussing the support structure that we have here at the clinic. So having our mental health professional, health coach, health education, things that we offer with the patients that they can hopefully, we can help them fill in the gap that may be occurring. Next slide.
Questions already for you. Thank you for that.
I'm gonna put it on speakerphone so that Dr. Hammond can listen in as well. If the echo is too bad, please let me know and I can. Can you hear us? Okay, great.
Did you have remarks that you wanted to make before we ask questions?
Sure. I'll give you an example of one of the first patients that we use this on, just to give you some practical application. But a lady who was, I think, close to 80, who had spinal lymphoma, previously treated with radiation many years ago with chronic back pain, leg pain from a neurogenic chronic pain source, and just having a lot of difficulty with controlling her pain, having her coming in with lots of resistance, always numerous side effects, and just very frustrating for the patient and for the provider. Long story short, she was one of our first test patients, and we did a profile, and this is a bit surprising, came back below basic literacy, and also had a personality type on the, I guess, the Smalley disc profile of influential, which would be like an otter, if you're familiar with that. And what that did was really changed our approach in terms of how we work with her, how many people in the team would then have touches on her, so that, and we do a lot of motivational interviewing here, but we adjusted motivational interviewing to be more compatible with her personality. And having that information, without information, we just did what we do. That information was really more focused and targeted on her learning style, and also address her below basic literacy and doing post visits and make sure things were written and whatnot. So it was a bit of a surprise, and it was helpful in terms of how she was, her pain management, I do think, improved, and I think she's doing a little bit better right now.
This is a really impressive assemblage of instruments and assessments that you're doing, Lane. There's a question from Heidi Delsky, who wants to know how and when you compile the data about a patient's personality and their communication and learning style. Are there specific tools you use? It sounds like you may have that tool yourself. And what patient cohorts have the lowest self-literacy?
To answer the first question, I compiled the data, I would say throughout the day, so as I receive patient profiles that have been completed, I just make time to go through and I call it interpret them, and put the data within the patient's social issue in the chart.
Back up. There's a written form. I think it's, I don't know, 4 pages, 5 pages long, and this is being piloted. And so they were sent out to our diabetic patients as a cohort, and then they were then sent back by mail or dropped off at the next visit. And when Lenny gets those forms, then she collates them and gets the information transferred, and I'll let her talk about how she gets that information off the questionnaire assessments into the computer.
Yes. So we received over 50% back from those diabetic patients, which is really helpful in process as far as things with both the tool and how we get patients completed, as well as the process of getting the information to the providers. Learning about the best way to do all of that as well. And as far as patient cohorts, I have literacy, we'll have pretty consistent with national data, and I would say that age is one of the greatest determinants of low literacy. Those that are over the age of 65 start to show indicators of health literacy. So that, I hope that answers that question. Let's see. I'm looking at the chat. Are there specific tools that we use? So within the patient profile, so Dr. Newman and I, we compiled it, we created it. but there are different tools that we have utilized others. So the newest vital sign is something, it's what we use to determine a patient's health literacy level, and I did not create that. Validated tool, like I said, on the nutrition label. So that's one of the tools we use, but then a lot of the other information is stuff that Johanna and I discussed and put in there to help get to know the patient better.
Could you talk a little bit about how you translate this assessment information into changes in the interventions you use or the way you interview with patients? Can you talk about how you apply it?
We're definitely still ironing out the details of that, but in knowing that we have low health literacy, we just naturally shift. I would say doing things, so try again to have that whole team approach, so utilizing as many people as possible. Dr. Hammond, are you going to say something?
Yeah, well, I'd say this again from a practitioner point of view, is really a crux, because you can have a lot of information about someone, but how do you translate that to something that can be utilized in a timely way, in real time, when the patient's in the office? And so it's in process, but we basically broke it into categories. I think the thing that I want to know as a physician, what is the literacy level, how do I talk to them, and what language, and how many syllables do I use in a word. And so we have, I think, 4 or 5 categories that we have just sort of that with sort of key words that will help the practitioner guide them in how to approach the patient. So obviously for health literacy we use what's standardized out there below basic proficient, things like that. Then this is a team effort, so the office needs to know how to approach the patient. So again, we use Smalley's personality tests, and it's nice because he breaks up in the animal types, and we can, otter lines and things like that. And actually that helps because it helps with the rest of the staff to kind of understand, how do you approach a lion? Well, it's differently than how you approach a golden retriever, so to speak. So it's more fun, it's more likely to be spreadable. That helps the personality of the patient, and it really does help you, be more directed with certain people, less directed with certain people. So you have the do's and don'ts of how do you deal with that personality, and that's what Lainey is teaching at all of us, how to deal with that. And then break it up into the other learning style is, and that's a visual auditory. So obviously with visual, we pipe up our monitor on the wall, and we show people things, or we write things down, or whatever. So that when it comes to education, we kind of stress their strong point, depending on what their learning style is. Then it's sort of free text in with the cultural literacy aspect of it, is how they, is there some ethnic, cultural things we should know about the patient in terms of how to deal with how they view and value healthcare. And again, that's sort of a group educational thing. So. And depending on what our particular population is that we're dealing with. So it's a lot of learning for the whole team to go through. And but once you've got it, then keywords will really kind of help you tune in pretty quickly to the profile of the patient and how to address them.
I have one general question for the whole group. And do you have any more to contribute right here before we end with some closing comments and a question or two?
I would like to ask all three and the physicians and nurses that are accompanying that is do they see these as permanent parts of their practice team? They're all innovative and creative. But do they see it now going forward as fundamental activities and skills that the practice teams need?
Yes. This is from Nydia.
Thank you.
Yeah, Lester, I'd say strong yes too. This is, I think a huge gap in healthcare that needs to be filled, and I don't know how you can actually take care of people if you don't know who they are. So yeah, this is fundamental.
Mike Swin also said that, we're hoping that compensation is going to keep up. We've built a model here that really gives a tremendous amount of support to the providers and the patients, and keeping up with it, but we're very committed to the model.
Yes, thank you all for a wonderful presentation. I have 3 minutes left by my computer clock, so I would like to pose one final question. It seems to me that in all 3 of these roles, the folks who are in the layperson role have been asked to have different kinds of conversations with patients. So a little more personal, or a little more face-to-face interactive conversations than you might have had in other positions or in a more administrative position. How has that been for you? Has that been a transition, and if so, how did you make that? How did you become comfortable with that kind of conversation?
And I would just say that I like to talk to patients, so definitely a highlight of my day. And I think we all, I would say, grow more comfortable with that the more we do it. But it's definitely not a science and art. Education is different, and so you kind of just have to learn to your style with the patient's style, personality, and so
I agree. This is Nydia. But it works vice versa as well, because the patient also, relationship with as well. Like, they get more comfortable, and when they come, they talk more than what we expect, which is, hi, what's your name? Do you have your card ID, so and so forth. They actually come and open up and say, hey, how are you? This is what happened to me last week. And they'll just bring up random conversations. So it actually goes both ways.
Thank you.
I would agree with both of those. I mean, first time you meet with a patient, it might not be that much of a visit. You might very little, but after, the first few times that you see them, and then you kind of establish a good rapport with them, and new workflows and new policies and just new programs come out all the time, and so I'm open to just new things, and with that I do help that there's a great support system on my team.
Those were wonderful comments, and it was really helpful learning from all these different perspectives, 3 very different kinds of positions that are patient-facing roles. So, Donna, next slide, please. Recording will be posted on Leap Commons website, and any further comments or questions you have could be posted there as well. And next slide, please. Our next and final Learning Community webinar will be on new roles in primary care, and we'll be holding that webinar on May 7th at the same time in your zone. So thank you all very much for attending today, and enjoy the rest of your day. Bye-bye.
Bye.